Welcome to the Clinicians Coffee Chat on Community Health Workers and Diabetes Care and Prevention. I'm Lily Cavallano, and I'm a project manager for the National Healthcare for the Homeless Council in Nashville. This project was supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under grant number U30CS09746, a national training and technical assistance cooperative agreement for $1,625,741 with 0% match from non-governmental sources. This information or content and conclusions are those of the presenters and should not be construed as the official position or policy of, nor should any endorsements inferred by, HRSA, HHS, or the U.S. government. The National Healthcare for the Homeless Council is a nonpartisan, non-commercial organization. This is the second of a four-part coffee chat series on topics related to diabetes. We call them coffee chats because they are informal conversations. We invite you to get a cup of coffee or your lunch and listen and discuss with us. This is an opportunity for us all to share questions, ideas, challenges, and support each other. We hope you'll share your questions and comments throughout. One of the best parts of the coffee chats is getting to hear from people doing similar work across the country. We also know that all of us are currently coping with the COVID-19 outbreak in our work and in our personal lives, and that may be front of mind right now. So we're going to have some space to talk about that too and share how we're all doing in our communities. This series was developed by the Healthcare for the Homeless Clinicians Network, which is the nation's largest network of providers of hands-on care to people who are homeless. The network helps members connect, learn from each other, and share best practices across the homeless healthcare field. If you're not already a member of the Clinicians Network, please join for free via the link in the resources box on the bottom right side of your screen. The Clinicians Network also has a Facebook group that's open to its members. It's a place where colleagues from across the country share their expertise and experience and engage on issues related to health and homelessness. You can join us also today via a link in the resources pod. Some instructions about how you can engage during the chat today. We want to hear from you, and we welcome your questions and stories throughout the chat. The more you all engage, the better the chat will be. You can type directly into the attendee chat pod on the bottom left of your screen. Your comments will show up to all participants, and I'll refer to comments and questions and to the panelists as they come in. So first up, let's see who we've got in the room today. I am going to post a poll question that you can respond to right on the screen. And the question is, what type of organization do you represent? Are you from a Healthcare for the Homeless program, another type of health center, a shelter, or another service provider? And you can click your answer right there, and it will show us everyone's responses. So it looks like we have Healthcare for the Homeless folks here, and then also other health centers and other types of service providers. Thank you. Our next poll question is about your specific role. And you can respond right on the screen. What is your current role at your organization? Are you a community health worker? Are you another clinician, an administrator, a consumer, do you work in government or in policy and advocacy or in another capacity? Looks like we have a lot of community health workers today, which is fantastic, and some folks working in other roles too. Wonderful.
Oh, I can't do both.
And one more poll question. And this is, are community health workers currently employed at your organization? All right, well, that's wonderful. We'll have a lot to learn from each other today. So before I introduce today's panelists, I also want to share with you all a few relevant resources that are available for you to access in the resources pod that's in the bottom right corner of your screen. The resources section has links to the Council's materials that we've developed over the past several years related to both diabetes and community health workers. Through the diabetes resources link, you can access the adapted clinical guidelines on recommendations for the care of patients experiencing homelessness at risk for or diagnosed with type 2 diabetes. There's also a guide that was developed in 2015 on integrating community health workers into primary care practice. And there's a brand new guidance sheet posted there of COVID-19 guidance for community health workers that comes from New York City that we just wanted to share in case it may be relevant to anyone who's attending today. Now I'm very happy to introduce you to our panelists today. They are Julia Dominguez from Healthcare for the Homeless in Houston, Denita Ngwu from Hennepin Healthcare in Minneapolis, and Esly Reyes with MHP Salud. Welcome. I'm going to invite each of you to tell us a little bit about yourselves and your programs. Julia, why don't you start?
Thank you. I am Julia Dominguez, Houston, Texas. I work with Healthcare for the Homeless Houston as part of a Baylor Family Community Medicine. We've been in this program since the pilot took off in February of 2014. This is our 6th year. And we were granted under 1115 waiver. We collaborate with the Search Housing, the Houston Housing Authority, New Hope Housing, who provides the SROs, which are single room occupancy only, one adult, and they have several sites all over the Houston, Harris County community. As we navigate homeless people through our program with the criteria of having chronic homelessness, multiple ER visits, navigate them into housing, apply for Social Security, Medicaid, Medicare, all of that umbrella, if you will, to establish a higher quality of life and so much more in that job description. So I would go on and on. It might be better directed. If there are questions, it's easier to answer with targeted questions. Sometimes, I guess, in this setting right here. I'm really proud to do what I do. We're SOAR certified, which is we can process all Social Security applications, although our search team has a more dedicated team to do that because it is very time-consuming. However, we are very active in that role. We have maybe 9 community health workers in our organization. In clinic are 2 of them, and the rest of us are out in the field at each housing site that we are assigned to. I have 38 clients currently living in my SRO, and those are the people that I case manage on a daily basis. So,
thank you, Julia.
Thank you. You're welcome.
Denita?
Hi, my name is Denita Ngwu. I work for Hennepin Healthcare. It's in Minneapolis. We're a level 1 hospital. I'm a community health worker that works directly in the emergency room in urgent care. I see patients that come into our system that have a priority of higher extreme. That just means they have a lot of health issues. Most of the time it's getting them connected back into our health care. It's looking at their charts, making sure they are using the health care system the correct way. Sometimes when you have a high priority, it just means that you have a likelihood to be to come back to our system and be admitted to our hospital. So we try to focus on finding out what works for that patient. I also sit on the board for Healthcare for the Homeless in Minnesota, and I also am a member of the Homes, which takes care of, that has a study for patients that are dealing with diabetes but are also homeless. And so with all that going on, it's a real focus about what the needs are of the patients. Here in Minneapolis, and at Hennepin Healthcare, we have 23 community health workers that work in our hospital. We're located in each of our primary clinics. And so, yeah, nice to be here. If you have any questions, you can definitely, write them out. I'll be happy to, answer them.
Thank you, Denita. That's cool.
Yeah.
Thank you. Esly, will you introduce yourself?
Absolutely. Good afternoon or morning, everyone. My name is Esly Reyes. I am a program director with MHP Salud. And to tell you a little bit about who we are, MHP Salud, we are a nonprofit organization with over 35 years of experience providing training and technical assistance to health organizations looking to build or enhance their community health worker programs. In addition to that, we also have direct CHW programming with over 35 CHWs working in our communities, which is pretty awesome because it gives us the unique understanding of the CHW in-ground work, the development, and I'm happy to be here and excited for this session as well.
Thank you so much. So our format today is that I will ask questions, the panelists will respond, and I also encourage you, the participants, to respond as well. You can type your responses into the chat pod on your screen, and if you have any follow-up questions for the panelists or any points that you'd like to share or new questions you'd like us to explore, just type those in at any time. So first up, before we get into the diabetes and CHW conversation, I just wanted to check in and see how is everybody doing with the COVID-19 outbreak. How is it affecting your work? How is it affecting your clients with diabetes? So I'd love to hear from the panelists and also the attendees. We'll take a moment here, and if you'd like to share anything in the attendee chat, please do.
Hi, this is Julia. If I may go first, is that okay?
Yes, that's great.
Great. We are, as of Tuesday last week, homebound to work under Baylor, which is, of course, Healthcare for the Homeless Baylor. So I am gratefully able to go to my site so far 1 day a week, and I usually choose a Thursday to make sure people are set up for the weekend. I do not do one-on-ones. I have an office set up in an area that I can see them, hear them, and still honor the social distancing of 6 feet. The property management at the property have shut down kitchen access, television community, library, computer, everything. So the residents are pretty much mandated to stay in their homes. They are able to go outside. In order to enter the building again, they have a key that automatically opens the door, but they have to have an ID. No visitors. They're very strict. You can't walk up to the front desk. They have it banded off with like that caution tape like at a crime scene. So you think that being at home on the phone is easy? No, it is very difficult, and it's very, very time consuming to do that. Clients are reaching out how fearful they are, that they feel they're leopards, like trying to grasp, but not everyone. A lot of the residents that live there understand what that means. A lot of our clients who have mental health issues and social issues are having a hard time understanding why they're being neglected and feeling alone. So my role, and even as a human being, is to continually stay in touch with them. I talk to some clients 10 times a day if that's what it takes. I just meet them where they're at. And then gather resources in the community, like churches that typically would come on site for coffee socials through their ministries, food sources. I'll get them and bring them in myself. I'm equipped with gloves, masks, etc., and make sure that those items are distributed to the residents, that I'm safe, they're safe. And so it is frustrating. However, again, I am able to go once a week, and that makes me feel good, but it's, client-based and makes them feel special because they are. So I could probably go on forever, but I'll let someone else. Our clinic is open. We have 2 clinics, one at Cathedral and then the main clinic on Caroline. And that clinic is open every day. They have their own system. Even for us to access the building, we have to do the fever each time to make sure that we're still not showing any symptoms of the virus, and just staying hopeful, prayerful, compassionate, and know that in time this will soon pass. We have a great support system. We have RNs on our team, and we work really heavy with them. Harris Health System. We chart in Epic here in Houston. Work with the Houston Harris County Health System, other outside facilities, St. Luke's, Methodist, staying in contact as care teams, and communicating directly with cardiologists. We have doctors calling us because they know they're canceling these appointments. So we do dedicated checks with the patients. We're trying to streamline medications and home deliveries, mail deliveries, and working through those sort of resources to help our clients stay out of the community. So those are just a few things that we're doing. Thank you.
Thank you, Julia. It's inspiring to hear all that people are finding ways to take care of the people they serve, even amidst really challenging circumstances. Anyone else want to add to that?
Yeah, I think that it's definitely challenging because a lot of the community programs that we used to have, and they were dedicated to a cause, especially from the ED side point, because it's more or less getting that patient to the next level, to the next step. So when a program is no longer because of the COVID-19, it makes it hard for us to say, well, where else can they go, or what else are there opportunities out there to get help? And so that's really our thing. It's really like who is open, who is helping our people, and how can we keep on being connected. That's basically it. I mean, on a daily basis, I'm here every single day, Monday through Friday, because I do patient direct care. I have to be here in the ED. So whenever I do see a patient that falls into my category, sometimes they don't even have to fall into my category, but most of the time they have to fall into the higher extreme priority, But it's really about getting them connected. Sometimes it's in-basking their provider, the nurses, saying, hey, your patient was in the ED today. This is what was going on. Can you reach out and call that patient and do a wellness call? Our elderly suffer a lot sometimes in that category because they're the elderly and because they're sick and they felt the need to come in and then they have to be discharged. It's like, can someone just call and see how they do it in about a week? And so, you know, that's a lot. And then also, you know, the programs that really help out, like the people that help with the foot care, are they still doing business? The people that help with shelter, are they still in business? Dental is huge. I had to go through my whole entire list that I created that took care of Medicaid programs and no dental, no insurance at all programs, to see who was doing business still. And believe it or not, a lot of dentists that take care of our Medicaid programs are doing business. They're only taking emergent, but you know, the people that come into our hospital, their dental pain is emergent. So we have we have a lot of resources. It's just try to tap into the ones that are actually still available.
That's right.
Wow, thank you.
Great.
Mm-hmm.
This is Julie. I just want to add one more thing about the dental, because we have a brand new state-of-the-art dental within our clinic, and so they are doing the same thing with just only emergency, and then our dentist, our team will then decide if that's an emergent. We can provide that at our clinic versus no access at the county level. So thank you for that, Denita.
Thank you. Esly, anything you wanted to add?
Yeah, just on that note, we also are homebound at the moment. All our CHWs are at home, and we still are encouraging for them to still be available to the community, right? CHWs are the trusted members of the community, and this is a moment of need that there's a lot of uncertainty, a lot of questions, a lot of fear, and while they're at home, we have come up with innovative ways for they to continue their outreach. So at the moment, they are going into their patient or participant logs that have happened maybe within the last 6 months, and they are calling them and seeing, hey, what is going on? Are you okay? Is anything? They are that bridge between health and social services, so they are connecting them to local resources that are providing help. Our community where we are located, we're in South Texas, so most of our population are Hispanic, Spanish-speaking, so maybe we have a lot of resources either in the media or online that are English, so our CHWs are actively working on translating them, and not only translating them, maybe sending them to the participants and then giving them a call. I want to explain to you, and that's the approach that we have been taking, just pushing them to continue being available to the community and present and visible as well.
Yes.
Thank you. What important roles CHWs are playing in this especially challenging time. Thank you also to Nicole Benson for typing in the chat box about her family is doing well, but brought up the point of having a child at home, and with everyone balancing sort of the work demands with also these things in personal lives that are impacted. There's just a whole lot to manage right now. I did want to mention that if anyone would like to talk further about the outbreak or hear more about how other communities are responding, the Council is hosting a series of COVID-19 town hall sessions. Those will start this Friday, March 27th from 1 to 2 Central Time, and then they're planned to go for at least 4 Fridays in a row. This Friday's session will have speakers from Seattle talking about the outbreak there and response. So I believe Caroline is posting the registration link for that session into the chat box. So please, if you're interested, join us for that to go into more depth about the coronavirus. So now let's delve more into the role of community health workers. We've already gotten into a bit about kind of the crucial role that CHWs play in their communities, but let's talk about how CHWs are involved in diabetes care or prevention at your organization. And let's start with our panelists, but I'd love for attendees to also type in your answers. Esly, you want to start us this time?
Sure, sorry, I was trying to connect my audio again. Sure, our community health workers, we currently have 2 different programs that are diabetes programs in our community. One of them is in Texas, the other one is in the state of Florida. So these programs constitute CHWs doing door-to-door outreach, and we have a kind of pre-test or an evaluation survey, right, where we want to, there's a couple of questions that they visit, they provide information, and they assess if the persons or the individuals are in risk for developing diabetes or pre-diabetes. From there, they try to recruit groups. And these are as a series of 6 sessions where they learn about healthy eating, about portion control, physical activity, support groups, family support, etc. And apart from that, we also have partnered with local clinics that they're offering their A1C testing for them. And CHWs are able to walk with them through this path of knowledge and behavior gain and change. And then as well, they are also connecting them with some clinics that are in our areas that are able to provide free care for diabetes patients. We have a high number of uninsured patients here in our area. So again, our CHWs are that bridge that are connecting them and walking them through. We have evaluated a pre and post test once they become participants, and they are in this 3-month-long program, and we have seen significant knowledge and behavior changes, not only from the participants, but it's making an impact to their family as well. So we have some testimonials from individuals that say, well, have learned to eat healthy, and that has not only helped me, but helped my family. And just to add one more thing, part of our program also constitutes integrating their family. So these groups that we form, they can be either in a community organization or resource, church, library, etc., but it could also be at the home of a participant, and a lot of the times we integrate their family. So what we have seen is a lot of the times the participant who is undergoing maybe diabetes or pre-diabetes, they are worried about their health and they want to make changes, but a lot of the time they do face not the lack of family support. They mention, I want to eat healthy, but maybe my husband wants me to cook a hamburger, etc. So these programs and the CHWs are essential because they bring the whole family, they explain the importance, and we have seen tremendous change from pre to post evaluations.
Wow. Denita, do you want to share about the...
Yeah, I can go next. Yeah, so me that I am in the emergency room and urgent care, it's really about focusing on the patient and their needs that day. I don't keep clients on my board or anything like that. I don't have a case management style. It is what you need that day, or how to get you connected to the next level, to the next step. So most of the time when you come in and you're seen by one of our providers, either I'm looking at the board just like they are, and notice that they need sometimes it's come up with refill medication. A lot of patients, they wait till the end that they don't have any medication or they have very little. Sometimes it's the affordability of the medication. You can't afford your diabetes medication. Sometimes it's you don't have insurance. So my job is to make sure that all those things are taken care of for you. Sometimes the things can linger on for like 2 or 3 days, but getting that patient to the next step is really about what do you need today. Do you have food to eat? Do you have a place to stay? Can you afford your medication? If not, let's get you to the right spot. The real cool thing about HCMC is that they have a lot of programs embedded into the hospital that are there to provide help to our patients. So we have a person that works with patients regarding their medication and able to afford it, especially diabetes medication. And she comes up and meets them while they're in the urgent care emergency room. So that's really nice. And then we can always, it takes nothing to make the call to the primary doctor or the diabetes clinic regarding the patient if they're already established that this patient is out of their medication. One thing that they do really well here is trying to get that patient in as soon as possible. That's like the focus, especially when they're homeless. It's like looking at what can we do today. If you get to a point where you do feel like we see a lot of patients that are homeless that necessarily don't like our health system that much, they're not comfortable here, then that's when healthcare for the homeless really shines. Because then I can do an in-basket to that team and say, hey, look out for this patient. They were in today. They need this, this, and this. And that usually works out for the better. We also have a lot of our other community programs, Avita that does our case management for the high case management. And they actually are able to go meet with that patient anywhere as long as they have a phone number. So it becomes kind of difficult, but in a way, it becomes more gratitude that you're doing something for that patient for today, and that lingers on for months to come. Hello?
Hello?
Denita,
Hello?
are you still there?
I am. Can you hear me?
Okay. Yeah, I think you cut out there right at the end.
Yeah, I'm getting static.
Yeah, me too.
We'll see if there's any.
Oh, now I don't hear static. So how much did y'all hear?
Everything.
Oh, yeah.
I think just the last little bit was cutting out.
Oh, yeah. So we rely on our outside programs that are really connected to Hennepin Healthcare as well, like Avita, and then there's also for case management we have People's Inc. And all these people work in our system for the better of the patient, and they do a lot with our homeless population. So my job is to make sure that connection happens, that they know that patient was here, that they're needing services. I can only do so much. I can give you what I have, but the outside community programs shine really well, especially healthcare for the homeless.
That's right.
Great. Julia, what would you add?
Well, thank you so much. So here in Houston, we have the Dawn Center, which is part of the City of Houston, Dawn Awareness Networking. And what we did, because part of our program is we target chronic diseases, and so we chose diabetes, and it continues to be, but we had a focused group that began in 2016. It was a 6-week, and we had of our 4 housing sites in each outreach CHW or care coordinator counting me at each of those 4 sites. So we did our RN split 2 sites each. So they enrolled. We had 29 participants that went through, and we arranged transportation to get them to our clinic for every weekly meetings that we had. The last 2 were at the actual Dawn Center where we did a big graduation. They got prizes. And if you will, let me pull this up. We, where is it right here, 1 second. It was a self-management, and so they targeted with sample plates, gave them plates of what their portions should be, showing them they could have come to the Dawn Center and be part of the garden, fruits, vegetables, and basically knowing how to check their A1C, medication management, and that was a successful 6-week program, and they're talking about doing another one this year, managing that. So we are on our autonomy with clients. Again, we can give them everything, help them do everything, but they have to control that. So what we try to do is just encourage, educate self-management with the diabetes. One of the problems we have with some of our clients is that they do not have income. They may get SNAP benefits or food stamps, and learning and teaching them how to shop, what to buy. The apartments, they have little microwaves and hot plates maybe to cook in their home, especially now since the kitchens are closed down. They can't do that. So what does that look like? So we're trying to target that right now. But, of course, our clinic gets free medication, so we're able to give them supplies and strips and glucometers and those types of diabetic supplies. Our role as a CHW is just to encourage, support the nursing who actually comes in. I have not did an A1C check. Our nurses jump around to do that, but as a collective team, we just continue to educate and keep people out of the ER because we can manage their diabetes. I will say a lot of the clients, we've had several that had very poor health and other issues, and we've lost them to multiple diseases, mental health, and so that's always a challenge, and finding family to support them, and a lot of times there are none, so we are their family. So yeah.
Yeah, thank you, Julia. So many ways CHWs support clients.
Oh, yeah.
There were a couple questions that have come in the attendee chat that I wanted to turn to. One asking about healthy tips for patients with diabetes who are also experiencing depression. I did want to mention that the council is actually planning a coffee chat specifically on diabetes and co-occurring disorders that's going to take place on April 8th. So if anyone is interested in delving deeper into that, we're going to do another 1-hour conversation just on that. Registration will be up on the council's website for that as well. But in the meantime, I'd love to hear from the panelists about how do you respond when you're working with a client who has diabetes and is also dealing with depression or maybe other behavioral health challenges as well?
Well, for us, I mean, in the ER setting, I'm sure it's very different because people are different when they're in those settings versus when they're really at home or in their natural state. So we just do the best we can to encourage them, support them, make sure they're linked to the medications and the supplies that they need, and let them be their own testimony within themselves in the community of how it works when you work it. What has been most powerful is during these times that several of our diabetes and other diseases have gone to heaven or they're not with us anymore. It really impacted the community about, wow, how important it is to really do this self-care, and we just keep educating them and the best that we can to that they are in control of their diabetes care, and So I think it's improved quite a bit.
Yeah, I can say. Yeah, I can definitely piggyback on that. I think because I work in the emergency room in urgent care, we see you sometimes at your worst or almost there. And so my job is not to judge you. I can't judge you. I have no idea what that means. So my job really is to accept who is in front of me.
That's right.
How can I help you today? You know, and asking the really, not the difficult questions, but questions people don't have time to ask. Did you eat today?
Right. Yeah.
Do you have somewhere to go today to lay your head?
Mm-hmm.
You know, do you have clothes that you could switch out of? Do you got socks? You got soap? You got a towel?
That's right.
You know,
That's
where
right.
you going after this? You know, not to get too personal with people, but enough to say, what are you doing right now? Because, you know, when you come in and you say, well, I need a refill on my medication, that's just one thing. But most of the time, they have multiple issues going on.
Yes.
And mental health is just one of them. Addiction is just one of them. And so not even dealing with that, you deal with the person in front of you. How can you keep them safe? And part of that is to shoot out to other organizations to say, hey, this person, you know, put a watchful eye on them. Or if they left, sometimes you get pissed off because someone pissed you off the way they talk to you. So then you didn't even get the help you needed. Or they discharge you before I can come back and see you. So then you're like, hey, you just look out for that person. But when you get a chance to talk to somebody, they really appreciate it. Like, thank you for, you know, this, and this. And then they assume that I work for somebody else. I say, no, I'm here. And if you need more services, just ask for me at the desk. And like, okay, no problem. And you'd be surprised how many people are willing and focused on, you know, thanking you and wanting that help. But it's the questions that you ask. And I think that most people in our organization here at Hennepin Healthcare, we're placed in positions because of who we are and how we adapt to a lot of things. And I know the reason why I was chosen to be in the emergency room urgent care because I'm blunt, but I care. And so the bluntness comes out, but it's more or less like, let me get you to what you need right now. And
I agree.
That is like a lot of pressure sometimes, but it's also great.
It's true. I totally agree. I tell my clients, you want me to be 100 with you, let's be 100 with me. It's a 50-50. And it's not always just a question. It's how you ask the questions. People know, I won't say they or clients, or human beings know sincerity when sincerity is real. And that is one of the things that I believe that we have been chosen because it's just a part of who we are, the natural characteristic of true compassion and understanding. Like, but I'm going to be straight up with you because people need that. I want people to be straight up with me. So tell me the truth, and keep drawing them back in because it's very, very important. We also have process groups. The residents will do community groups within themselves because, peer is strong. Peer community is strong. So I like what you're saying because it's true. You probably go on and have a two-hour coffee chat. Yeah.
No, we got to live the same life, don't we?
Straight up. Yeah.
Yeah, I think, you can't, I think that a lot of people, even when they come and shadow me, they're like, you have such a rapport with your patients. I'm like, yeah, because, I'm not here to, I only have one face. So whatever you see or how I talk, this is me. So,
I know that's right. That's right. I like that. I only got one face, yeah.
I only got one face. I don't use big words that I know you can't understand. No.
Yeah, that's
and just
sure.
to add on that, I feel CHWs do have the battle between, they show empathy, but they're also leaders, right? They're also someone that the patients look up to. So maintaining that balance and being also one approach that we take as an organization is for them to be aware and make networking connections of organizations that are offering mental health services, because when it comes from that referral comes from a trusted person and a leader, right, that is not judging them, that is understanding them, and they're referring them to these other organizations, they're more likely to follow up and go and get the care that they need as well.
True. And also when we're sending and referring people to other agencies and stuff, we have a report that we're just not sending Sally to somewhere that we don't know. So before they go there, it's doing all that important talk face-to-face or whatever with wherever we're sending our patients to go to, that it's just not, just there's no communication. We have to have an open line of communication at all times to the best of our ability, and that's building the network. I've got care coordinators that continually hear about us and want to know who we are. We did presentations at Ben Taub, LBJ, for their social workers, because social workers in a hospital, will send a sick client at 6 o'clock at night on a Friday on a bus, and that's the last place they need to. So linking those social services with us about how important it is. No, you're a social worker. You give them a taxi voucher. How would you like it if your family member was stuck out at 6 or 7 o'clock at night? Come on, man, be real. So you have to be tough, but you have to be professional and all that at the same time. So it's like very challenging. Every time someone says something, I could just go on a tangent, but I don't want it to be considered that. But we touch so many crevices in people's lives that you can't just say it in an hour. It's tough, but I'm so grateful for this opportunity to talk to other people, because we then are our own resources of support to help our clients, because they're important. Thank you.
Yes, and I think you all started to really get into these unique skills and traits that community health workers bring to the team that are really critical, that other providers may not have. And so thank you for getting into that. I did want to relate a couple things that have come in through the comments. Jarlene pointed out that the council has created a nutrition guide that may be useful to attendees. And if you look in the resources box on your screen, and if you click that diabetes resources page, it will take you to our website, and the nutrition and diabetes guide is linked on there, so you can access it that way. And Darlene also pointed out in the conversation about depression the importance of physical activity and finding ways to get people moving and in fresh air, and that some organizations have started walking clubs, and even in the current situation where people can maintain the 6 feet distance but still have a way to have some activities. Another question that came in from Brett Dennis Duke. So let's get into a little bit about how the workflow works. So in your communities, how does a person experiencing homelessness become connected to a CHW, and then how does the CHW help them stay connected to the healthcare system? Denita, you want to start us off this time?
Yeah, that's the problem. So my job is one of the things that's so cool here is that if you come into our system and you are a priority of higher extreme, and you don't have primary care, but you have all these underlying conditions that's going on, I definitely would, what I try to do, it all depends. If you're homeless, you really have to look at the whole picture. Like the shelters let you out at 6 o'clock in the morning. So getting you a 2 o'clock appointment is just not going to work, because you're just walking around our city until 1 something, and you probably will forget and no show. So my job is to make sure you get to that appointment, whether it's, hey, let me get you a meal, a breakfast voucher, come on back, and then I'll walk you over there. to your appointment, but also it's that connection to the community health worker, the clinical coordinator, and the social worker, and the primary care doctor. All four of those work in this circle for the healthcare. I don't know if you guys ever heard of the healthcare homes model, but it really is that focus of the patient is in the middle, and everyone else works with that patient to make sure they have the best life in healthcare for themselves. So basically, you're sending them to sending a referral to say, hey, this guy would be, or this person would be great for the healthcare home model. And then from there, it's more or less like what are their needs, what kind of things they need. So you have to basically take what we call a lifestyle overview and kind of a snapshot it to the things that stood out to you that this patient could possibly need. If they can't read or write, it would be nice if they do that. If they were homeless, it'd be nice if they do that. And so all these things take place, but even before they get to that part is knowing that patient and what they have going on that day. Are they ready to go to primary care? You can't just assume someone wants to get into our health system. Some people just can't do that right now. And so we have clinics that are based like that where you can drop in or, have a more easier pathway to their clinic. And so that comes very important too. But then finding out, did they eat today, where you staying today, if the clinics aren't what and looking at their track record or the path in our system, Epic is really amazing where we can see everything you've ever done in every encounter, the time you have spent in Minnesota. And so we can see.
Do y'all have care
at the clinics?
Do you have care everywhere?
Yeah, we have care everywhere, but we can see.
Yeah, I love it.
We have the upgraded version, so we can see if you went to other hospitals. We can see if you were connected to healthcare for the homeless. We can see if you have outside appointments or if you have an outside provider, and that comes in handy because sometimes the outside provider is not connected to us. But my job is to make sure that you get an appointment with that doctor. But also, this is the key. Where are you staying? Where are you at now? Where are you going to be? If you're at one of our shelters, it's getting that transportation for you. So most of the time, if you're high and extreme and you're homeless, I'll offer that taxi. All of our Medicaid programs offer transportation as a taxi option for our clients.
That's right.
So it's not really it's something so simple a lot of people don't know about, and it's really about like, hey, how can I help you get to this appointment? How can I make it easier for you to get to this appointment? And that's basically it.
And one of the things about being in a medical facility, you don't require a 2-day notice to call and set up that transportation.
No.
They automatically, that's a waiver, automatic to get them home. So,
Yeah, and even we even like have our own account with one of the taxi companies. So if it push comes to shove, we just do it from our account. If they don't have insurance, so if they don't have insurance, the first thing is to get your pending status. And then our pending status is because we do have financial counselors right here in the emergency room. And that she goes back and forth. But then it's also what's the next step? Transportation. What's the next step? Making sure you're ready for that step. Making sure that everyone is invested about your needs. Because once you get into the room and the doctor comes in, the first thing they ask you, how can I help you? And so if you can't voice what you need, it's very hard. So our community health workers are invested. I'm like, hey, can you look out for this patient? Go see this patient when they come into your clinic. And they're like, yes, of course. And so they'll go see you to be your advocate.
Oh, absolutely. It's like I'm a bodyguard. Who are you? Well, I'm yeah.
And it becomes like a really great connection. So everyone, even though I don't keep clients, I give other community health workers clients, and that's where it kind of makes the magic happen.
Yes, ma'am. I like that. That's true.
Awesome. Esly, is there anything you'd add about how folks get connected to CHWs in your community?
Sure. For us, is more as a community perspective. We promote flexibility, like the other panelists here present mentioned, is a key trait for CHWs, and we often hear that CHWs do not have a day the same than the next day than the day before, right? So we believe that CHWs are able and should meet patients or participants where they are. And one of the processes that we take is we provide an intake evaluation or assessment where is a holistic assessment of their needs, while they need care, they need food, housing, transportation, etc. And that kind of creates a work plan for CHWs to act upon, right? Once they do that, CHWs are ready to get to work, start doing services, connections, start calling other agencies, because one of our motto is to provide the holistic approach to any patients. So just to wrap up, I think flexibility of CHWs and being navigating innovative ways to be able to impact patients is really important, and the workflow changes every day. Yeah.
Yes.
Thank you. We're at the 5-minute left mark, so I've got one final question for the panelists, and it's a two-part question. First, what advice would you give to someone who wants to add a community health worker to their team? And then part two, what advice would you give to another community health worker about how to take care of themselves to be able to continue in this work? And Esly, do you want to start first this time?
Sure. I would like to mention the first part and advice for anyone who would like to start. You're hearing it from an organization that's all we do, community health workers, but we have different resources that show the great value that they provide to a health center, right? The integration, they ease the coordination of services, they ease also the communication between provider and patient, they're that link. So for sure, I would say start learning about the great benefits of integrating CHWs, especially there's some peer review articles. We have some resources, especially if they have to go up to decision makers within your health center. So that's the first. And then the second question, can you repeat it again? I'm so sorry.
Sure. What advice would you give to another community health worker on how to take care of themselves to be able to continue in this work?
Sure. One thing that we always say is self-care is a need, right? CHWs need to be okay holistically to be able to help others. So we provide different activities or techniques for prevent self-burnout, right? We say we have a PACE, and we always try to give them all the tools for organization to have more organized days that will prevent anxiety or stressful between I know a lot of them have a big caseload, right? So so just as an organization, we provide tools for them to be able to manage stress and anxiety. And I'll pass it to the next panelist from here.
Julia, how about you? What advice would you give?
Absolutely, the self-care. And so, the EMDR, the eye movement that you can do with, I've got friends that are social workers and stuff, and I always can debrief and, because there have been times, I don't want to go on because we don't have very much time, but you have to recognize when you need to take a step back, and that it is okay, because we are so human being, we have so much compassion that we can get caught up, and you've got to recognize you got to do that and be okay with it. Because how we present ourselves is like we're in the fishbowl. And so we also use a lot of MI, which is motivational interviewing, and we internally can use that for ourselves as well. And we rate our own value to do that in order to continue to help others. We got to do us and be honest and talk with your team. Yeah.
Thank you. Denita, what about you? What advice would you share?
I would say definitely try to get as many community health workers as you can in your organization. I can't say enough how important my position is. We are the gap. We're that person in the middle from healthcare and outside world. a lot of the places. I mean, before the Affordable Care Act, I truly believe that, when you came into a clinic, you were rushed and you didn't feel like anyone heard you. But here, when the Affordable Care Act came along and the community health worker came really, really known, it was like, why not? Why isn't this here before?
Yeah.
But we were here long before the Affordable Care Act. So knowing that, you just have to focus on, hey, there's someone that can be with that patient to help them fill out their forms that they need, can talk to them about what's going on, to get them the right resources. I become like this guru of resources, but I always tell people, go out and seek the resource, but know the truth of the resource before you give it to someone. That's
one of the things. Oh, sorry.
Yeah, no.
We have mandatory monthly meetings, and all our CHWs from across our agencies, we come in as mandatory. We always have presentations that we present to each other, outside agencies, and we're able to, just speak openly, and it's the coolest thing. So
we have retreats that we do, and most of the retreat is really focused on self-awareness, self-healing. But one thing I can definitely tell every CH worker out there is leave it at the door, because you're going to come back tomorrow with and it'll be waiting for you, but leave it at the door. And that's really about leaving the stress at the door and then living your life outside of here. Do not bring what you have felt or you have done into your private life. Just leave it at the door. And it's really a hard thing to do for a lot of CHWs because we hear so much stuff, and that's people's energy just bouncing off of you. And so you have to depress once in a while. So even take time to just be calm in the moment. Meditate is big. So we encourage that. We have CHW Alliance that we rely on for a lot of our programs and advice, and just other CHWs that might be going through a struggle. It's time for them to just meet other CHWs that could basically help. But that is one thing I could definitely say for every CHW that's out here: leave it at the door.
Yep.
That's it.
Well, thank you so much, Denita and Julia and Esly.
You're welcome.
Thank you all who participated in the chat today. This was fantastic to hear from your experiences. You'll receive a brief evaluation that's going to be posted after the chat. So the participants, please take a couple of minutes to share your feedback so that will help us plan for future sessions. Like I said, the next coffee chat about co-occurring disorders is going to be on April 8th. So I hope you'll join us for that if you can. And then the fourth of this series is actually about nutrition. So that date has not been finalized yet, but watch your email for that once it's set, and I hope you'll join us for that as well. So thanks again, everyone. Stay well, and talk to you soon.
Thank you all. God bless.